Welcome to the recorded version of the Grantmakers in Aging web seminar, The Scaling Marketplace, a new strategy for funders seeking to achieve large-scale impact, featuring Alex Rossides, CEO and co-founder of the Exchange, Christopher Langston, Program Director at the John A. Hartford Foundation and Chair of the GIA Board of Directors, and John Feather, CEO of Grantmakers in Aging. From October 7, 2014. This event was made possible by a partnership between Grantmakers in Aging, the John A. Hartford Foundation, and the Social Impact Exchange. Technical and production support is provided by the American Society on Aging.
Thanks so much, Steve, and welcome to everybody to Conversations with GIA. This is part of our continuing series of monthly webinars on critical topics in aging. Today's session is entitled The Scaling Marketplace, Helping Funders Achieve Large-Scale Impact. As Steve said, my name is John Feather. I'm the CEO of Grantmakers in Aging, and I'm delighted that so many of you have joined us today. Before we begin, I want to thank those whose support is making today's webinar available free of charge to our audience. The John A. Hartford Foundation of New York provides continuing support for this series, and today we have with us the Social Impact Exchange. We also want to thank the expert team at the American Society on Aging for providing technical and production support for the series. Funders often support the development of important new social innovations, only to see them wither away after initial support ends. How can we take new programs that have proven successful and help them grow to be large scale? Today we are going to discuss the scaling marketplace, an exciting new way for foundations and other funders to achieve greater impact through their grant making. This is an initiative of the Social Impact Exchange. The scaling marketplace is helping to build a growth capital marketplace that connects funders to effective nonprofits that are scaling their work in health and education. First, we will present an overview of the model and the investments currently offered through the scaling marketplace, with particular focus on those that benefit aging adults in the U.S. And then we will share the experience of one of the original members of the Scaling Marketplace's Health Working Group and how that participation has supported his foundation's goals. As we go to the next slide, I want to welcome today our speakers who have been deeply engaged in this process from the beginning and understand the opportunities and challenges that it presents. Alex Rossides is the CEO and co-founder of the Social Impact Exchange, and Christopher Langston is Program Director at the John A. Hartford Foundation and Chair of the GIA Board of Directors. Welcome to you both.
Thank you, John.
Thank you.
Alex, let's start with you as we move to the next two slides. Tell us what's on our agenda today and what our objectives are for today's webinar presentation.
Sure, John, and thanks so much. We're delighted to be collaborating with GIA. The goals today would be simply to help those who are on the call to learn about the Social Impact Exchange and particularly the scaling marketplace, and to explore several of the opportunities in the scaling marketplace that are trying to achieve large-scale impact, and use those as examples of the work to give some concrete, tangible case studies. They're real examples that are being implemented currently. And, of course, we really want to hear from Chris Langston, who's a member of our Health Working Group and has been deeply engaged in this work, and hear the perspective of a peer funder who is supporting and actively participating in the marketplace. And then most importantly, perhaps, is really to share, and for those who are participating today, to learn how to get involved and to get involved in ways that work for them and for their foundations, and will hopefully lead to helping increase their impact.
Thanks. We move on past the next slide to the one following that, if we could. And if we could then go, Alex, to tell us a little bit about the Social Impact Exchange itself and how it is different from other efforts to help projects scale their work?
Sure. So the Social Impact Exchange is a national membership association, and it's dedicated to addressing the challenge of how to achieve large-scale impact in critical issues, particularly health, education, and poverty alleviation. And its goal is to establish a system that enables much broader collaboration among foundations and other funders, specifically in support of scaling up effective initiatives in the nonprofit sector. And we really define scaling up. We usually use the term scale the impact, and we define that broadly. The way we think about scaling is not only program replication, though that's certainly a valid strategy for getting to increased impact. But in addition to that, to get to scaled impact, we think about certainly policy initiatives and policy change initiatives, practice dissemination, systems change efforts, could even be social movements or new products that are developed and rolled out. So many ways to achieve scaled impact, and all of those are included in the work. The exchange has about 7,000 members, doesn't cost anything to be a member, and there are about 150 funders on working groups, and working groups really drive the efforts and the activities of the exchange. And the scaling work is geared to local, regional, and national funders, and that's because the kinds of initiatives that are increasing their impact are local, regional, and national in scope. And so it's an effort and a system that incorporates certainly not just national funders, but quite importantly, and actually the majority, are local and regional funders. And we created the exchange because there was really an acknowledgement in the field that we haven't been able to consistently move highly effective interventions to broad scale, to reach millions of people that need them in communities across the country. And without being able to do that as consistently as we'd all like, it makes it difficult to address our tough problems, which are certainly at scale. Bill Clinton had a very appropriate quote. He said, quote, while he was president, "Nearly every problem has been solved by someone somewhere. The challenge of the 21st century is to find out what works and scale it up." And in many respects, that's the rationale for the exchange. And I'll just mention that there are many impediments and barriers in the social sector, as we all know, to moving things to broader impact. But one of the major reasons that it's so difficult is that it's expensive to do it once you get beyond, an earlier stage of demonstrated innovation and you're trying to move things to scale. It just costs too much money for any one funder, and often even for a few. And so as we analyzed that particular major problem, it really cried out to us for a system that enables funders to collaborate much more regularly and easily around the opportunities that have shown that they really do work. And in essence, that's the work of the exchange, is to build that type of system, make it a lot easier for funders to connect locally, regionally, and nationally to these high-impact opportunities and be able to collaborate around their funding, and in other cases, some of the other resources that different stakeholders bring to the table. And just to address your question, John, of what makes the exchange different, it really is that we take a systems approach, and that we're trying to build, sometimes we call it a marketplace, that can much more easily connect funders to nonprofits that are growing and scaling their impact. And in that sense, It's much more of creating a helpful layer of connecting infrastructure, and that's a fairly unique role that we play.
Well, as we go to the next slide, we've mentioned the word working group several times. Tell us about the working groups. What is their goal, and how do they work?
Sure. No, the working groups are really a central piece of the system, so to speak. To make it easier to collaborate in the process of getting interventions to scale, we created a two-stage process, and they're both the stages driven by funders. And the first stage is led by working groups. Working groups are essentially funder collaboratives. They're made up of 20 to 30 national and regional, in some cases local funders. And if we take the example of our health working group, it's the same makeup and consistency. And the working group has a particular role. Its purpose is to identify high-impact, scalable interventions and contribute a portion of the funding, so-called lead funding, if you will, to support those initiatives' growth, and then to share those initiatives with broader networks of funders. The working groups are open, so the membership in them is open. They're not exclusive in any sense, and nominations to the working group can come from those who are not actually in the working group as well. And the real impetus behind the working groups is to see if we can bring together a leading group of funders that wants to take a role in being able to together jointly identify just really exceptional models and helping them to take the first step in bringing together the capital and resources that they need for their growth and their scale up.
If I could just add at this point, I think one of the things that all of us value in philanthropy, and one of the things I think is really important, is the flexibility and the individual approach that different foundations bring. I think that's very important. And so I want to reassure that participation in the working group does not oblige anyone to do anything in any particular way. And I think we were very reassured in that the group set its own ground rules for operations. It set its own standards and processes as developing this system that Alex was describing. And at the end, even the process of co-funding is not, okay, here, make a contribution blind of some X amount. Really, I think the way to think about it is the process creates a framework within which you know that you're working on a project that others are also investing in, that it has a strong evidence base and it has a good model for scaling its impact and reaching more people. And then within that framework, you can find the way as a funder that best fits your interests. So you might be funding within a region, you might be funding through a particular strategy of scaling if that was something that was important to you. So really, it's a framework for appreciating evidence-based opportunities to really reach a lot of people and solve problems.
Yeah. As we move to the next slide, and thanks, Chris, for those words. Before we do, I want to remind our audience that at the end of the presentations, we will have the opportunity for you to ask questions. To do so, you need to go to the tab on the right side of your screen, the blue drop-down box that says questions. Go ahead and start typing in your questions at this point, and I will then be reading them to our panelists a little bit later. So you can go ahead and start doing that at any point. So as we move to this next slide, we've already touched a little bit on the health working group, and here are the members. What do the working groups look for as a potential project for scaling? How do they know when they found the right effort?
Yes, it's a great question, and I'll share with you the process that they use, and to be sure, it's a combination of art and science, one that we're all learning as we go forward on. And as you'll see in this process, as Chris alluded to, we sometimes refer to ultimately the participation by working group members as opt-in, and meaning that they don't put money, as Chris mentioned, into a pooled fund. They all take a look at opportunities based on the fit for their own work. So the way the process begins is that interventions, nonprofits are nominated to the working group by members or, again, by outside folks based on some pre-established eligibility criteria, and those eligibility criteria were developed by consensus of the working group. The spectrum of issues, say in the health working group, runs across the gamut of issues in health. So there's no specific issues that are generally forbidden, for example. It's really a broad spectrum of opportunities. And the eligibility criteria are the first screen, and there are three basic, simple eligibility criteria. I'll mention them and explain sort of why they were put into place. One is an evidence base. So nominations need to have a third-party quantitative outcome study that shows that their work has been effective. Secondly, they need to have demonstrated a certain level of scalability, meaning that they are not early-stage or startup opportunities, that they've demonstrated that their work is effective in a variety of settings. And third, they need to have a business plan or a growth plan or a strategic plan outlining how they're going to take the next steps in achieving their scaled impact. And those business plans are pretty rigorous in terms of laying out a number of just pieces to their growth plans, including their projections about where they're going to serve folks and the costs and the revenues, what their scaling models consist of, what is the competitive environment. And so those eligibility criteria were established so that these opportunities truly could be ones that have the opportunity to broadly scale, opportunities that generally one funder would have difficulty funding on their own. So again, if it's early innovation, one funder can do that. So these are for those things that are really poised to spread or go very deep in a particular state or a city, for example. That said, there is not a very highly rigid process. Some opportunities don't have business plans, and working group members agree to fund business plans. Some opportunities do not lend themselves to quantitative studies necessarily, and so there is some flexibility in how those eligibility criteria are applied, but those are the general ones. And once opportunities are deemed to have met those eligibility criteria, and it's a combination of review by staff and working group members, there are due diligence teams that are formed by the working group members themselves. So working group members that are interested in those opportunities will join a due diligence team, a team that will do a deeper analysis of the opportunity. And all the working group members have agreed on a framework for the big categories of due diligence that are reviewed. And just to quickly touch on a few of those, the teams will look at whether the evidence is pretty strong that this opportunity is highly effective. They will very much look at the scaling strategies, whether it's a replication model, whether it's a train-the-trainer model, whether it's delivered via an online mechanism, varieties of ways that the different interventions have developed their strategies to scale their impact. And they will also look at the organization's capacity and, importantly, their financial sustainability at scale, and that's obviously an important component, because as these organizations grow their impact, even though it's not always a linear process, they do have larger budgets. And after the due diligence teams have reviewed an opportunity based on, again, those agreed upon big categories of review, the members themselves on that team make a decision whether they think this is an opportunity that should really move forward. And the working group members across the whole working group will then decide whether or not they would like to put in the lead funding for that opportunity. And as I said, the funding itself is a decision that each individual foundation makes based on whether it's a really good fit with their work. And if an organization has received 25% of what their business plan requested for their next stage of growth, that's the point where the opportunity is then shared with other funders, which we'll talk about in a minute. But so it's really a two-step review process. There are eligibility criteria, and we can send those around, and they're on our website. And then there's a deeper due diligence that the working group members do.
All right. As we go to the next slide, we're going to now talk about some examples of the projects that you're currently working on. But I do want to remind our audience to go ahead and go to the question box, which you'll find as a drop-down box on the right-hand side of your screen, and go ahead and start typing the questions that you may have for our speakers at the end of this presentation. So here's the payoff. Here are some projects that are particularly applicable to older persons that you're currently working on. So I think both of you are going to tell us a little bit about the various projects and what they're trying to accomplish.
Great, and I can start a little bit. And Chris, why don't as I talk about different ones, feel free to jump in or however you'd like, and then we can talk about, of course, how different funders who are not on the working group can gain access to the actual opportunities and how they are distributed. Why don't we talk a little bit about impact first, and you can see the logo there. This is a terrific example of what to us is probably the most evidence-based model we have seen with several large-scale randomized controlled trials demonstrating its efficacy. The model is a mental and behavioral health model that embeds a care coordinator in the primary care physician's practice to manage depression and other related mental health conditions. The model itself has a very high rate of reducing depression for those individuals that are identified in the primary care physician's offices as, again, having depression or other anxiety disorders. The interesting piece here that we were not aware of as we looked at the impact model, 80% of mental health cases are handled in the primary care physician's office. 20% have any kind of significant success in remediation, whereas the impact model, the majority, way over 50%, have very strong reduction in their depression. The model the scaling strategy for the model is what we would call practice dissemination, but the national office impact at the University of Washington does the technical assistance to help embed the model into primary care physicians' practices, and so it's essentially a TA model where they are training the practices on how to establish and embed the model. It is just far and away just one of the most effective interventions that we've seen, and there's also a policy component to it where they are working on getting the reimbursement for the care coordinators through Medicare, Medicaid, and other insurers, which would really move the scaling of the particular practice to much higher levels. And it's just a terrific intervention for a very specific condition. And this is one that was nominated by the John Hartford Foundation. And so I'm going to pass it to Chris to add some context here. But we were just delighted with this particular intervention.
So thank you, Alex. I think there's a couple of points I wanted to amplify. I think you captured the efficacy of the model in improving people's health outcomes very well. So we nominated this. It went through the vetting process. I think that our longtime grantee, the University of Washington Advancing Integrated Mental Health Solutions Center, AIMS, really found the questions that the due diligence staff of the Social Impact Exchange posed very thought-provoking, helped them think about how they might add some different strategies to their work around trying to scale up the model. So that was very productive. Having had this gone through the due diligence process, we actually have an early success experience in that the Helmsley Trust, whose interest is particularly in rural America, the Upper West and Midwest, has recently decided to come in and co-fund 2 sites that are part of a program that we have been funding through the AIMS Center to replicate the model at rural federally qualified health centers. So we are very appreciative to Helmsley and to the Social Impact Exchange, which introduced us to them as a potential partner. And I think it really goes to the whole fundamental question of why we're doing this. This is a very big country. We are a large foundation in aging, a mid-sized foundation in the overall picture of things, and our total endowment is less than half a day's Medicare spending. So if we're going to try to get effective interventions that don't just fall out of a market economy and don't make somebody money, but yet really serve the needs of people, we need lots of friends and lots of partners. So the Impact Exchange has helped us get that.
Thank you, Chris. It's really helpful context. And just one other point to build on that, and the Helmsley experience. One of the things that is important to note, I think, and Impact is a good example of this, the models that spread to different parts of the country and grow their impact are not necessarily just following a cookie-cutter approach in every community. And there is room for adaptability in the implementation of these models in different communities. The example of Impact and working with Helmsley illustrates that on one level, that some of the communities where Helmsley particularly focuses its grant making are extremely rural communities. They'll sometimes call them frontier communities. And so there are discussions that took place about how Impact could tweak some of its model to address that level of rural environment. And so it's just one example of just how these models will adapt to some degree. Obviously, they want to maintain fidelity to the pieces of their model that generate the results, but it's very much of a opportunity to engage and think about what pieces can be customized for different environments.
Well, Alex and Chris, I want to make sure that we have plenty of time for our question period. So if you could fairly quickly then go through the other 3 examples for us, and then we'll move on to some further discussions.
Sure. Let me do that quickly then. One of the organizations, the Center for the Advancement of Palliative Care, is a different model no less compelling. CAPC, as it's known, is a leading field builder, I think the leading field builder in the field of palliative care, and they have been responsible, with the help of others, in embedding about 1,900 palliative care programs in hospitals across the country. And they are now working to enhance those palliative care programs, as well as launch an initiative to do a similar comprehensive palliative care in communities where the palliative care programs would be embedded in community-based organizations and other agencies as an important piece of the field building. And they do their work via an online set of tools, through technical assistance, through consultations. They're building the standards for the field for anybody who cares about chronic care, end-of-life care, palliative care. This is the entity that is really leading that movement, and it's obviously a huge issue in the country today. Another one of the organizations, the YMCA's Diabetes Prevention Program. We all know that diabetes is a terrible disease affecting older adults in great numbers. And this particular program, again, is just an incredible solution to the problem. It applies a CDC randomized controlled tested intervention that brings individials into a group setting where they focus on healthy living and healthy eating. There are about 87 million pre-diabetics in this country, converting at a rate of 8 to 12% a year. It is and will be a major cost driver in our health system, and yet the majority of people who go through this program do not convert. It's obviously upstream. It's a prevention model, but it's distributed through the YMCA's in their physical locations, as well as other locations in the community that the Y runs. And the Y is 5 miles away within 5 miles of 95% of the population in the country. So it's a great distribution system for this program. And so for those who want to really address a chronic disease that's terrible and preventable, it's a great solution. And then finally, ECHO, another transformative opportunity. ECHO leverages technology. It really leverages video conferencing to provide training to rural underserved communities, and particularly to clinics, primary care physicians in those clinics in rural underserved communities, for how to address complex conditions. It started, and now it now works in about 12 different complex condition categories. It started in hepatitis C, where specialist physicians from academic medical centers, and the first one was from the University of New Mexico, use video conferencing, weekly video conferencing with 13 rural clinics in New Mexico. And weekly, they did a training on hepatitis C through the case study method. Well, what happened after a year and a half, the rural clinics with just primary care physicians, prior to the ECHO, they had essentially not treated their hepatitis C patients because they didn't know how. Well, in a year and a half, they had better outcomes than the academic medical center, better cure rates than the academic medical center. And ECHO has just exploded since then. It's in about 12 hubs across the country, delivering a variety of specialty care trainings to rural communities and underserved communities across the country, and now actually globally. So it's a great delivery system transformation model, and it's pretty broad in terms of the various conditions that it addresses. And I don't know, Chris, if you had any just sort of additional.
If I could just jump back to the why. I think this is worth illustrates a couple of points. This is not one that we nominated, and despite the fact that we have 6 professional program people all focused on aging and health, so we are a lot better off than most funders in the aging area for whom they also have many other responsibilities. This was still not something we were knowledgeable about. We did not know about this program or how far the Y had already taken it in scaling it within its various branches. So I believe this was introduced by the New York State Health Foundation, and we were very interested and have entered into negotiations and beginning to develop a grant to help expand this. I think it also illustrates one of the points that Alex made earlier, which is that the way you scale something is not always a straight linear path. It's not always let's buy one more or have one more building or one more agency in one new town. Their strategy actually has a combination of things, one being policy work, say with Medicare, to make this a benefit that people at risk for diabetes could get payments to the Y for on behalf of offering them this service, as well as direct replication across different YMCAs. And we think that this is a tremendous opportunity to partner with a new organization that we hadn't ever funded before. So we really appreciate this opportunity to learn as well as to share things that we've learned.
Well, thanks, Chris. As we move to the next slide, let's continue to talk to you as one of the a representative that's been involved in this area since it started and is one of the first funders. You've touched on this a little bit, but let's come back to it more formally. What did the John A. Hartford Foundation hope to achieve by being involved in this effort, and how did you end up being a part of this?
Well, I think that we start out always with the sense that aging issues don't get enough attention as a part of philanthropy or other parts of society. I think the normal statistic that we like to throw around from the Foundation Center is that about 2% of philanthropy goes to aging, and older adults are right now 14% of the population, and a much bigger part of the healthcare world than that 14%. So we are always looking for partners and always looking for ways to magnify our impact. We know very painfully and very personally that we don't have enough money to get everything that works to everybody who could benefit from it. And I really think that is a moral imperative, and at least from my perspective, especially in healthcare. One can talk about everything being local, but human nature and human biology is not local, and things that work are really owed to everybody who could benefit from them. So we face a very daunting challenge, how to scale across the whole large country things that I think should be basic health benefits. And as I said earlier, to do that or even come close to doing it, we need a lot of partners. And this is a mechanism for finding them in a wholesale as opposed to retail way was very attractive.
Okay. We've talked a little bit about the due diligence process and the nomination process and so forth, but hey, what about that have you found particularly useful? Is the process itself a useful one for you and the other staff members who are involved?
Yes, and again, as I said, despite having what I am very proud as a crack professional staff working 110% on aging and health issues, I was very impressed with the due diligence process supported by the Social Impact Exchange staff. They really know a lot of the scaling mechanisms. They know the business planning much better than we do. And they are also very flexible. They are not doctrinaire in any way, and they've been a pleasure to work with. And so have our grantees said who've been participating in the process. So we really feel like we've gotten good value out of that. I don't think anybody knows the perfect magic way to scale something up. This is something we're all learning about, and having a community in which we can learn, I think, is also very valuable.
I'll ask you one last question, but I want to remind our audience that after this we will turn to your questions, so please go ahead and write them into the question box that you find on the right side of your screen. You just open the question section there and type that in, and I'll be reading those in a moment. So, Chris, the last question before we turn to the audience's questions is, if you're able to use this as a way to expand opportunities. How do you see local and regional foundations in particular benefiting from this kind of process?
So I think that there are a lot of benefits, and let me just start with an example that predates the Social Impact Exchange, but we've worked with a number of locally oriented funders whose mandate, say, is New York City, like the Fan Fox and Leslie Samuels Foundation. And one of the ways that they have actually gotten involved in both CAPC and Impact, just as an example, is by funding local healthcare delivery organizations to then buy technical assistance from either the Ames Center at Seattle in the case of Impact, or from the Center of Advanced Palliative Care in the case of hospitals implementing palliative care. So that's the kind of partnership that fits under the Social Impact Exchange just as well. We've talked to regional funders like Helmsley, others who might want to, say, support the adoption of palliative care across a whole state or a whole region. And those are opportunities that are available to regional funders. Finally, if there was a funder who had a particular affinity for a particular method of scaling, say, policy and advocacy work, I think that is a component of many of the scaling plans and would be something that people could pull out and fund if that was their preference. So, we're really just bringing great opportunities that have been thoroughly vetted, already have friends, that 25% buy-in, so you're not going alone. And there will be an aggregation of both the money and of the parents to the program. So I think that's what we're offering to local and regional funders.
Great. At this point, we're going to turn to your questions from the audience, but please keep adding them to it. And actually, Chris and Alex, will start with the topic that you just touched on, Chris, which is that the examples we talk about are all wonderful programs that are specific to health conditions that are common in older people. But are there examples of social policy issues that where the policy part is kind of the main focus? Or are most of these, at this point, direct service kinds of efforts? And I'll let either one of you. You want to start with that one, Alex?
Sure. I guess the first response would be that pure policy initiatives would be quite welcome in terms of nominations to the working group, and I think there's a great appetite for strong policy change initiatives amongst the working group, and I think in the broader funding community. I think that in terms of the specific opportunities that have emerged from the working group to date, there is obviously an emphasis on a combination of practice or program and practice and policy. And what I mean by that is I think that the folks at Impact, the folks at the Y who were running the Y diabetes prevention program, the folks at Impact, both, for example, and certainly true of CAPC as well, all three of them are leaders in their field trying to achieve particular policy changes. And they see that as a critical scaling strategy. And so if a funder wanted to focus on the policy change piece with respect to diabetes or Impact, it's a very tangible opportunity. It's around payment system reform and reimbursement for care coordinators, reimbursement for a preventive program that has evidence that it saves the government and society a lot of money. In the case of CAPC, there are similar kinds of policy formulations that they are working on. So I guess that the policy initiatives are embedded into many of these opportunities, but they are nonetheless quite important in terms of getting to the large-scale change. And so it's quite true that these are combination plays, but the policy piece is embedded in them.
Chris, anything to add?
I think Alex says is true. The thing that we also know is that at the end of the day, it is, of course, the payment policy that will determine the sustainability of a lot of these interventions and transformations of the delivery system. The one thing we know, the good news about healthcare is we already spend plenty of money. We're just spending it wrong. So at the end of the day, we need to change the way we spend in order to actually buy better health outcomes. But it is those health outcomes we're most interested in. We don't want policy for the sake of policy. We want to be able to advance things that actually have evidence that they improve people's health.
Yeah, it's a combination. It's if you have policy without practice and implementation, then it doesn't work. And if you have really effective program implementation, but you don't have the payment incentives aligned properly and the right policies, then it's really not going to scale. It's going to struggle. And I would just say that this is very much a local, state, and national policy relevant discussion. So many of these opportunities will go state by state and change Medicaid policies statewide or dual eligible policies. And so there's a state component as well as those who would like to work on the national level.
Okay. Could you give us some sense of how much money we're talking about? Are you talking about raising $500,000, $1 million, $5 million, $10, $100 million? Sort of a frame of reference or a degree of scale here. And also you mentioned that development of business cases was sometimes part of the work. Could you talk about that a little bit? I'll aim that one at you, Alex, first.
Sure. So the second question first, in terms of the development of the business case and the business plans, it's just a truism that most nonprofits, even if they have done studies to show that they're highly effective and they have a good scaling model and they've actually demonstrated the implementation of that model on some level of scale, they often have not had funding or just the ability to develop a plan for the next 3-4 years that is an organized scaling plan that lays out how they're going to disseminate or scale up their impact, what their capacity needs are from a system standpoint, from a talent standpoint, from a revenue development standpoint, and certainly from a program implementation standpoint. So all of the pieces that go into figuring out how you're going to get to that next level. It's standard in the for-profit sector, of course. When businesses grow, they develop their business plans for each stage of their growth. And so, since many nonprofits don't have that, the working group did not want to mix terrific opportunities. And what they said was, we will consider funding the business plans. They're usually an order of magnitude less, of course, than the actual implementation of the plan. So anywhere between $150,000 and $200,000. It could be less, could be a little bit more. And the exchange staff will help the nonprofits identify consultants. In many cases, they know consultants as well. And we provide some very, good, but not any secret sauce, just the basics of what really should be in the plans and help guide the nonprofits to make sure that they, at the end of the day, they come up with a really solid plan. The amounts of money that are being raised really depends, and I'll share with you the amounts for the different organizations we talked about, or broadly the amounts. But what's important is that the amounts contributed by different funders in different areas of the country really differ between national funders and regional and local funders. So many of the nominations to the working group have business plans that call for $10 to $20 million over to be expended over a 3 to 5 year period. So that's a substantial raise, and that's why we are in existence. It's very difficult to raise that kind of money in this sector for these kinds of initiatives. It does take collaboration, and when you think of a national funder, I think that terms of contribution levels. I mean, you can imagine that the working group putting in 25% of a $16 million business plan is $4 million. It's substantial, but those are substantial entities on the working group. I would say the average has probably been about 10 to 12, maybe actually. In any case, most of the plans then have their local implementation components to them. So what's really important to note is that if Impact is going to expand its programming in the state of California or New York State, or the Y is going to implement 4 sites in Illinois or in Texas, that the amounts needed for those site implementations is far, far less. I mean, they're embedded into their growth plans often, but you're talking about contributions at a local level. Contribution of $50,000 to $100,000 can often be very important. And in fact, it's really important to build a marketplace with funders who can provide that level of support locally and consistently. So even though the full raise is large, and national funders might put in $250,000 and up, local funders, which are a critical part if they're going to 25 new locations, et cetera, their amount of contribution is much less. So it does get cut up, if you will.
So let me just add quickly, I think specifically we have $2 million towards CAPC's growth plan, and we have $1.5 million as lead funders towards Impact AIM's growth plan, and we are talking around $500,000 buy-in to the Y diabetes prevention program. So, there's a difference between lead funder and somebody buying in, but we'll see what happens over time. The more important thing, I think, to think about these dollar figures is to put them in context of the need. So I was just at a meeting last week, and I think the kind of thing we all are at frequently, where the observation was that they'd reached 5,000 people, and this is very substantial for a newish program, very good regional implementation, cost-effective, better health outcomes. But the horrible truth is that it's 10 million people who need this program. And that's the kind of thing we're seeing over and over and over again. At our best efforts, working alone, working independently, working in our traditional model, we reach thousands, and what we need to do is reach millions. And the burden is on us as stewards of this money in philanthropy is to do the best we can to not reinvent the wheel and certainly not reinvent the flat tire, but really try to meet those people's needs.
That's very useful and very wise. One more question before we move towards having our panelists give us their final words of wisdom today. You mentioned that you also work in social justice and lower income issues as well as education. But in these issues that we've been talking about, they're all health issues. At this point, is there a plan to move to the social aspects of aging, or for the time being is the frame of reference going to remain in health?
I can jump in. For the Social Impact Exchange, our plans are to establish, and they're really in part capacity constraints and resource constraints, but to establish a poverty alleviation working group. We hope in late 2015, it might be 2016, which would encompass a broad set of issues. Certainly some of the social aspects of aging, particularly those related to income, but also quality of life broadly. That's quite important to us to establish because we do see the interconnection between health, poverty, and education. We do have a platform that sits somewhat outside, but is also has the working group scaling initiatives on it. We have a platform and I'll mention a couple of our platforms, but we have a platform called the Social Impact 100, the si100.org, which has about 100, now about 110, scaling initiatives on the platform. It was developed in conjunction with Schwab Charitable Trust, and so it's a very easy to navigate web platform. On that web platform, you'll find poverty alleviation opportunities as well as health and education, some of which relate to an aging population. It's a beginning of building out that third area of work in poverty alleviation. The working group nonprofits, it's not a bad time to just take 30 seconds and explain how folks can access these opportunities in the work of the working groups. The nonprofits that are emerging as scalable opportunities from the working groups can be accessed on a web platform, which we will also send around, www.scalingmarketplace.org. And it's a very easy to navigate platform that will also give you not only the basic information, but has in it the business plans, the evaluation reports, and all the due diligence for each of these opportunities. We, in essence, are creating a network of funders, so anybody on the call that might be interested, who want to simply be part of taking a look at the opportunities that fit with their area of funding. So we're creating a network of funders who essentially sign up and say, yeah, I'd like to receive any opportunities that fit with what I fund, whether it's generally aging or a particular issue within aging. And then that becomes a nice investor network that can take a look at opportunities, and that's essentially how the working group will disseminate its scaling investments to other funders, and we're finding funders through wonderful collaborations with entities like GIA and others. And so we'll send around, I'm sure, after the webinar, some information about how folks can sign up for being part of that network. Again, as Chris mentioned early on, it's entirely opt-in. There's no assumed commitment of any capital just because you're part of the network. It just gives everybody a chance to see the opportunities and actually to review the ones that fit with what they fund.
Well, thanks. At this point, we're reaching the end of our hour, so I want to give our speakers a chance to give us their final thoughts about this area. So, Chris, we'll start with you.
Thank you, John. I just want to observe, I think, the congruence between the Grantmakers and Aging mission and the Social Impact Exchange. Our mission at GIA is to try to help grantmakers do a better job of preparing a society for aging and to make society a better place to age. And this bringing together of grantmakers within the exchange, sharing knowledge, sharing opportunities, I think is very congruent.
Alex?
I would just say, so similarly, our mission really is in many respects to help grant makers increase their impact in those situations where to do so at scale requires collaborating, and we hope that through our work we're able to lift up these models that really are truly effective, that can change lives, and be able to share them in a way where funders can more easily participate and engage in the conversation.
I want to thank Alex Rossides, the CEO and co-founder of the Social Impact Exchange, and Christopher Langston, Program Director at the John A. Hartford Foundation and Chair of the GIA Board of Directors, for their participation in today's program. We thank you for all you do to make life better for older adults. I also want to thank the John A. Hartford Foundation and the Social Impact Exchange for their support of today's program, as well as the American Society on Aging for their technical expertise. And finally, I want to thank all of you for participating in today's webinar. Have a great day.